following the webinar. I'd now like to introduce our speaker for today, Mr. Jim Winkle. Jim Winkle has trained hundreds of physicians and clinic team members how to sustainably implement SBIRT workflows into primary care and emergency room settings. As the creator behind the SBIRToregon.org website, Jim has designed clinic tools, screening forms, and video demonstrations that have been widely adopted by health professionals around the country. At this time, Jim, if you're ready to go, I can go ahead and turn things over to you.
Great. Thanks, Sarah. All right. Welcome, everyone. Thanks for giving me the opportunity to take a little bit of your special time today. I know it's not easy to attend webinars. I myself tend to sign up for more than I actually am able to attend when the time comes. So I'm glad to talk to you today, and happy to share what I've learned on my journey into trying to make electronic health records support SBIRT workflows in medical settings. And quick disclaimer, I'm not an informatics specialist. I'm just a humble project manager in Portland who has a SAMHSA grant training residents and behavioral health specialists how to do this. But as part of doing that over the last 5 to 6 years, besides just training people in SBIRT processes and setting them free in their clinic setting, we quickly learned in our project that it's much more sustainable to train more than just clinicians to try to create a supportive environment in that setting to ensure SBIRT happens, and that includes optimizing the EHR. So one also note here is these slides, of course, will be made available to you later, but some of the things I referenced during this presentation will be available on this website. The screening forms, the way we've used screening tools, formatted them on paper in a way that's convenient for clinics, those can be downloaded in different languages on our website. Some of the smart phrase examples that I'm going to get to later are on there, billing code information, so it's kind of a one-stop place for helpful info. So today's presentation, I kind of outlined it this way. What do we want our EHR to do when it comes to SBIRT? My previous experience with this, kind of under 3 different projects, and then some specific examples of tools we've built, and I'm going to use Epic as a default. I have a little experience with other EHRs, but it's mostly Epic, so I'm going to use that as an example, hoping that it's applicable, even if you are not an Epic user. And some of those tools will be what we call the health maintenance function, a best practice advisory, flow sheets, and smart phrases. So we're going to take a look at those. And then, of course, lessons learned. So people don't have to reinvent the wheel to a great extent. I want to share what I thought made it easier and what made it harder trying to do this. So what do we want our EHR to do in terms of SBIRT? I think there's 3 main points, 3 main principles. One, a lot of times the EHR kind of drives the workflow. So if that's the case in your clinic and you want to implement SBIRT, hopefully your EHR will facilitate an SBIRT workflow. We want to track what goes on, either for quality improvement purposes or you're reporting to a performance metric somewhere. You want to know probably how many patients got screened, how many patients got brief interventions, how many were referred to treatment, or what else was going on. So we want our EHR to track those things. And then probably we're going to bill a lot of times for reimbursement or for metric purposes. So we want to bill appropriately and we want to document appropriately. So these are all things the EHR ideally should be able to do. If we were to break down that further into more detail, I would propose this is what we'd like to do specifically. When we're implementing a SBIRT workflow, it could be just in your clinic, which is fine, but it could be within a teaching hospital setting that has 4, 5, or 6 multiple departments that serve different patient populations, have different clinic staff dealing with this, and you're probably not going to have your own EHR function to a large extent just for your own clinic setting. You may have to share that EMR across departments, so it has to apply across departments. We'd like our EHR to alert us when and which screening tool is due. A lot of times patients are supposed to be getting these forms like once a year, and what computers are supposed to calculate ideally when a patient's due for a screening tool. And then when someone completes a screening tool on their alcohol or drug use, we'd like to record their score, maybe their total score, maybe their individual answers on a screening tool, maybe just the zone of risk they fall into, whatever it is, we want to record that. And then perhaps what intervention is indicated. Sometimes it's just brief advice, sometimes it's a brief intervention, sometimes it's referral to treatment, or maybe brief treatment, and maybe that could alert us to what is indicated. And then the progress note. Many clinicians may be already familiar with tools like smart phrases, which automatically populate the progress note with language that supports billing codes or just makes it easier and quicker for a busy clinician to complete a progress note. We want to apply the correct billing code and diagnosis codes. Those are usually required as part of a visit. Let's have the EHR do that for us. And then the last three things here, we are still working on in the experimental stage, but perhaps you'd like to automatically print out a patient handout, like a 2- or 3-page handout for your patient about their specific substance use. So that should be something the EHR could do. Probably want to produce reports for our own purposes, for quality improvement or for metrics. The EHR should be able to do that. And then in the future, if you aren't doing this already, probably the future is tablet screening, using a tablet and perhaps through an email portal where people could fill out screening forms electronically before they even arrive to their visit. So specifically, I think these are the main things we hope our EHR can do for us in regards to SBIRT. I forgot that I animated all these. So, and others, there could be things that I left out here. So I definitely admit that I didn't cover everything. So today we're going to look at a workflow example to demonstrate what tools I'm familiar with. And I've not built these tools personally, but I've advised the IT specialists who have built these, sat on committees with clinicians on this. And so there's two workflows we're going to look at. One is outpatient, one's emergency department. And not to say that this is the correct workflow for primary care, but this is a common workflow. So you'll notice there's three kind of main categories of clinic team members involved: reception, a rooming staff, which is usually a medical assistant, and then the clinician. And perhaps, if you have a behavioral health specialist, a warm handoff from a clinician to a behavioral health specialist. And there's three main patient populations: adults, adolescents, and pregnant women. These are all populations that should get their own screening tool. They have screening tools that work specifically and better for those specific populations. So the workflow works like this for a lot of clinics. With adults, instead of giving everyone once a year a 10-item questionnaire, they opt for alcohol, 10-item questionnaire, drugs, and DAST. Most clinics start with a brief screen. It's a single validated question for alcohol, a single validated question for drugs. It's very quick to fill out, and that's given to everyone once a year at the front desk. Then when the patient is roomed by the MA quickly scans that brief screen. If it's positive, gives an audit and or a DAST, which the patient hopefully fills out while they're waiting for the clinician. And that happens in the exam room. Clinician walks in, looks at that audit or DAST, and if it's positive, does a brief intervention or a referral. So that's the adult workflow, a two-step screening process that happens at reception and the exam room, and then the clinician walks in to do an intervention. With adolescents, the commonly used screening tool, of course, is the CRAFT on top there, and that is not a two-step screening process typically. The CRAFT is only 6 questions. It covers both alcohol and drugs, so there's really not a pre-screen separate from that that's necessary. So it's a one-step screening process, and it's usually given in the exam room. A couple reasons. One is because there's no pre-screening, we don't need to give it out in the waiting room. The other reason is adolescents commonly come in with a parent to a medical visit, and to ensure confidentiality, which will get us good screen results, we need to do that in the exam room when the patient's alone from the parent. So that's another reason why it's a one-step process. The 5 Ps, I don't know if you're familiar with this. There's a couple tools out there for pregnant women. The TWEAK and the T8 address alcohol only, I believe, with pregnant women. We found the 5 Ps a couple years ago, and it's our screening tool of choice with pregnant women. It covers tobacco, alcohol, drugs, intimate partner violence, depression, and only 8 questions. Validated tool. You can download it from our website. That is also a one-step screening process. Doesn't need to be given out in the waiting room because it asks about intimate partner violence. Sometimes patients come in with their partners. It's not good to ask them to fill out a screening form in the waiting room when a partner is with them. It should be done in the exam room. So I will say, however, that pregnant women's screening for SBIRT is kind of in theory only at this point. We have not had good luck at OHSU to have our OB-GYN department do this yet. And at a recent SAMHSA grantee meeting, this came up where several people around the country, SAMHSA grantees, we were talking about how it's been difficult to get OB-GYN folks on board to consistently implement SBIRT with their patients. And we're not sure why. It could be because in some states there's penalties against the law for pregnant women to use substances while they're pregnant, and so that acts as a barrier for OB-GYN folks to address this. Whatever it is, I will admit that we do not consistently screen pregnant women yet, but in theory, this is how the workflow probably would work if we did. It would be a one-step screening process in the exam room. So that's enough about that workflow. Hopefully this resembles what you do in your own settings. An emergency department is kind of similar as far as a two-step process for adults, one-step screening process for adolescents, pregnant women. The pre-screen typically happens in the triage room where patients are asked all sorts of questions. So that single alcohol and drug question is typically asked during triage. If the patient's positive on one or both of those, it's usually a nurse or social worker in the back room, either at bedside or in the exam room, kind of when there's a break in the action after the reason for the visit has been addressed and they're just kind of waiting for discharge. Whenever there's a chance, a social worker will follow up with that patient with a full audit or DAST, and if positive, we'll do an intervention or referral. I've not heard in emergency departments of physicians being very involved in this process. Sometimes they may do a warm handoff to the behavioral health specialist, but as far as I know, they usually don't do the interventions. And with the craft and 5 Ps, that's probably something done also at bedside or exam room by a social worker in the back. So those are the two workflows, outpatient and ED. Today we're going to focus mostly on outpatient as an example. And by the way, I see there's a question there. I'm a prevention specialist. Okay. So if you have a question, feel free to use the raise your hand button or the chat and let me know. I think it's best to answer questions as they come because this is a little complicated and if I have to go back several slides to answer a question, it may not make sense. So Sarah will alert me if there's a question. So feel free to ask at any time. I'm going to use my cursor here. So when we talk about workflow, it kind of resembles a pipeline. One thing leads to another, which leads to another, and unfortunately, this doesn't happen as often as it should, so there's leaks in this pipeline, and sometimes it's because the actual step is not performed, but sometimes it's because it was performed, but it wasn't captured in the EHR. So as you probably know, when you're trying to track other things beyond just SBIRT, there's probably more of something going on that is actually documented for. And that's too bad because we want to know what happened so people get credit if they're trying to meet a performance metric. And also a slide here to show how I believe optimizing the EHR fits into the overall picture when we're trying to implement SBIRT. Because obviously the greater goal here is not just to fix the EHR, it's to implement SBIRT. And there's other things involved in this. So how I see this fitting in is when I am asked to give a training presentation at a clinic or health system, the ones that are successful in implementing this compared to ones who aren't are the ones who first get buy-in from leadership. So it's important that you get buy-in from people in charge that you're doing this. A lot of times the clinic agrees to a training. They just send their nurses and social workers to a training. The providers don't know what's going on. The nurses come back excited to do this new workflow, but it just dies out after a couple of weeks because the providers don't recognize the screening tools and they don't know what to do. So it's important to buy in. Then the next step after that is within your clinic, identify a workflow. Perhaps it's what we saw on the slide a couple slides ago, or something that just fits your clinic best. Whatever it is, identify it. And then before you roll it out, this is where you probably want to optimize your EHR. And later in this presentation, I'm going to talk about lessons learned on what that involves as far as time and money to do that. After you've optimized your EHRs, then you need to train your staff. You need to train your staff on how to perform SBIRT processes with a patient, but also how to use these new EHR tools. You should probably identify a champion, probably one medical assistant, and then maybe one provider who's the go-to person on making sure this is happening, a resource for other colleagues. And then the last thing is utilize clinic tools. There are pocket cards, reference sheets, patient handouts. These are all things that kind of help the process go. So optimizing the EHR is an important part of this, these components. So my experience doing this, why am I talking to you? I'm a project manager for 5 years where we were tasked with training residents how to perform SBIRT with patients. But like I mentioned earlier, we quickly found that we couldn't just train them in a captive setting and then slip them loose and expect that this was going to happen. We went into each clinic setting. We had 7 different clinics sharing 4 different EHRs, and we worked with their IT folks to build some tools to track SBIRT processes for purposes of our own evaluation. The next thing that happened was OCHIN, which is a conglomerate of FQHCs and CHCs around the country, had a grant to also build some tools for SBIRT. They share one EHR. They share Epic, OCHIN Epic, but there's a lot of clinics sharing that one EHR. So I helped out, I guess, in an advisory role on building those tools. And then what's currently underway at OHSU, which is a large teaching hospital in Portland, is we also have Epic, our own version of Epic, and it needs to apply across about 5 different departments who want to do SBIRT. So I also am in an advisory role with that. So using experience from these 3 different projects, today I'm going to kind of show maybe like what the best parts of those projects were. So the earlier project, when we trained those residents in their different clinic settings, they used OCHIN Epic, OHSU Epic, and Centricity and Meditech. The goal here was just to track really 4 separate steps for our own evaluation purposes. So we didn't rely on billing codes at the time. That was not important. We didn't make a smart phrase for the progress note. We just wanted to capture how often was the brief screen given, how often was the full screen given, how often was a brief intervention done, how often was a referral to treatment done. OCHIN project was different. By the time OCHIN got a grant to build tools in their EHR, the goal was to not just capture those 4 steps, but to drop the right billing code, because in Oregon the billing code is used as a metric to measure how often SBIRT is happening across the state as part of our Medicaid program. So like I said, a lot of FQHCs around the country is headquartered in Portland, and they all share their own version of Epic, and they are finished with their first phase of building these tools. At OHSU, on the last phase of piloting what we've done there, the Department of Informatics there took on this project because multiple departments need to meet an SBIRT performance metric. And so we got together a committee of clinicians from all the departments, which is not easy, and we met monthly. We went through a lot of pilot projects, and I'm going to share what we learned from that. So let's start out with first, if you're using Epic, I'm going to use this as a default. Like most EHRs, before you do anything to it in regards to SBIRT, you may learn that it doesn't really offer you much as a default from the beginning. This is the screenshot of the vital signs page from Epic, and it has things we expect like blood pressure and pulse and temperature and all those things, and it has tobacco. It says there, are you a smoker, or never smoker, smokeless unknown, but it doesn't have alcohol or drugs. I don't know why. I don't know why Epic chose to include tobacco, not alcohol and drugs, maybe because tobacco was a meaningful use thing. The point here being is if alcohol and drug screen should be part of the vital signs, Epic as a default does not have that yet. But if you were to go a little further into Epic, into the social history, which clinicians may or may not do consistently, there is a little section there. There is a little part for alcohol and drug use. It's not part of the vital signs. I don't know how often this would show up during a visit, but it is there in social history. And if we take a closer look, it's interesting. They have a little alcohol use and drug use box. I'm not sure where they got this. It doesn't make sense to me. So alcohol use, you have little radio buttons there, not asked, no, or yes. It does not say what question you should ask. So it doesn't give you a validated question, screen question. Presumably, it just assumes you're going to ask your patient, so do you drink? Or how much do you drink? Or do you use drugs? Which is not necessarily validated questions. The other problem is this other box with use per week and type. I don't know where those numbers came from or the type. A standard drink is usually 0.6 ounces of alcohol. There it says 0.5. The amount of alcohol per week has 9.5 ounces. I don't know what any of this means. So this is not helpful, not based on evidence, not based on validated screening. And drug use is the same. Another use per week for drug use, here's my pointer here. I don't know what these numbers mean either, 1, 2, 5, or 10. We don't have a standardized dose for drugs in this country like we do for alcohol. So I don't know what it means use per week, how many times, but is that like 1 joint, 1 milligram of cocaine? We don't know. So the point here being is, as a default, Epic, like most EHRs, probably does not do a good job facilitating consistent screening for this or letting you know what to do. So we have to change it. And when we change our EHR, we probably have limited abilities to change it at different levels. If you're a clinician, you can probably tailor your EHR to some extent to what you want to do. Clinic-wide, you can do some more things, and if you're part of a clinic system, you probably have your own version of the EHR as a total, and you can do more things. But some things can't be done unless they're done by headquarters, which, like for Epic, is in Vernonia, Wisconsin. And if you wanted, for example, to make alcohol and drug screening part of the vital signs, you probably can't do that. It's probably something that only Epic could decide to do. But there are other things you can do. So we're not reliant on Epic coming out with improved versions that one day hopefully will do this appropriately. It does allow us to have tools we can build our own, and we're going to look at those tools. Like I said earlier, we want our SBIRT EHR to apply across departments. May or may not be an issue for you depending on where you are. But if you're part of a hospital system where there's other departments, you're probably not going to get your own version. You're probably going to have to share it with other departments, and that means applying towards different patient populations and different users. So you can see the different patient populations there, and if you're a family medicine clinic that's going to share the EHR with pediatrics, pediatrics doesn't really care about adults, pregnant women, I guess pregnant teenagers, and the way to interpret their specific screening tools might be different for their clinic compared to yours. OB-GYN is different, of course. The workflow is different in emergency rooms. And then you have your users. In primary care, like I mentioned before, a lot of times reception will be involved a little bit. So I mean staff and the clinicians and hopefully behavioral health specialists if you're lucky enough to have them. But in other settings, the reception isn't involved. In pediatrics, it's just the rooming staff and clinicians. In emergency departments, clinicians aren't really involved much at all. It's the nurses and behavioral health folks. So all things to consider if you are trying to improve your EHR across different departments. And a quick review here of the screening tools. When we mention patient population screening tools, this is what I'm going to refer to today. So many clinics use these screening tools, the brief screen, audit, and DASH for adults, the CRAFT 5Ps for adolescents and pregnancy. So back to our workflow page, let's look at what this might look like in a real setting. So assuming that an adult comes in for, I don't know, follow-up on diabetes, whatever visit, and he is due for his brief screen. This is where the reception plays a role. And the brief screen, by the way, just a little more detail here. Like I said, it's 1 alcohol question, 1 drug question. So the alcohol question, how many times in the past year have you had 5 or more drinks in a day as a man or 4 as a woman? If a patient answers 1 or more, we don't really know what risk category they are in at this point, but we do know that they should fill out the longer questionnaire they audit. So 1 or more will qualify you to get an audit when you're roomed. Drugs, how many times in the past year have you used a recreational drug or prescription medication for non-medical reasons? Again, 1 or more, you'll get the DAST screening tool when you're roomed. So very quick screen. So how does reception know when to give this to a patient? Patients do not need to get this typically more than once a year. Patients come in more than once a year, so we don't want to give this to them every visit. So how do you determine that? Well, one way we figured out, kind of a basic way, it's a manual method, is in Epic, when someone checks in, typically reception looks at this box here. And as part of this box is this patient messaging option. If you click that, this pop-up comes up, and it has a free text box. And what we trained our reception to do at the time, a few years ago, before we became more advanced in this, was just to manually type in, screen tool given today or screen tool next due on this date. So some free text to type in. And that way, next time the patient checks in, the reception looks at this box and sees if it's been more than a year or not. That's nice. It's better than nothing, but of course it relies on having to type in stuff rather than just being alerted to it. It requires a little bit of calculation to see if it's been 12 months in the last time. It's not ideal, but for some clinics this may be what they have. So here's the manual method. The automatic method, which is what we did with Ocean. What you see there is a function called the Department Appointment Report. This is what reception also look at when a patient comes in. And you can tailor this appointment report to include whatever preventative service or function you want. And so we built in SBIRT health maintenance status. HM stands for health maintenance. So when a patient checks in, reception looks at this, and you can see there's these little green check marks here. That means that this patient is not due for this, but this patient is. It's like a little clock symbol or something. So essentially, Epic in this case has automatically updated the status of SBIRT screening based on the last time they got it, and will just tell you as a receptionist if it's due or not. So ideally, that's what we like. The other way to do this, the health maintenance function, can be done in the department provider schedule too. So if you wanted to go into an individual provider schedule, there's another column here for SBIRT that you can add in. Notice also there's a PHQ-9 here. So many clinics do screen for depression too. So often the SBIRT workflow really pairs with the depression workflow. They're commonly used together. So this is pretty good. Whether you look at an individual provider schedule or the patient, Epic will tell you they're due for their brief screen. What is this health maintenance function? It's something that can be built in Epic. You don't need permission from Wisconsin to do this. It tracks when something is due. The question is, when is this updated? When do we know that a patient has been given a brief screen? The drawback of this workflow is the receptionist may give the brief screen to the patient, but they do not record that. They rely on someone in the back office to record that that was done, which we'll see in a little bit. But when that data is entered in the back office, then health maintenance is updated. It's updated nightly. And we're going to look in a little bit here at the flow sheet and a smart phrase. Those are the two tools we use to enter in that data, and that updates the health maintenance. So a few screenshots here from our training videos, which you can watch on the website to show how this works. So the patient checks in, receptionist notices on the screen that they're due for their brief screen. In our clinics, we use these yellow folders to put the screening piece of paper in, just because it gives the patient a little privacy, and it kind of acts as this bright yellow beacon to other staff that there's a screening tool in there. Given to the patient, patient sits down in the waiting room and completes this, and it's only 2 questions, so it takes 10 or 15 seconds to complete. And when it's time to be roomed, the medical assistant comes out, greets the patient, and says, do you mind if I take this from you, and I'll take it back to your room. And the medical assistant rooms the patient and quickly scans the brief screen to see if it's positive or not, which is very easy to do because there's only 2 answer choices. You're either positive or you're not. If the patient is positive, each exam room is stocked with alcohol and drug screening tools, the real audit and DAS forms. So she grabs one from the file folder and gives to the patient. And in addition to taking blood pressure and the other things that MAs need to do, asks the patient, would you mind filling out these questions? If you have any concerns or questions about this, ask the doctor. And typically there's some time a patient has while waiting for the clinician, and we're trying to take advantage of that time and that's when the patient typically fills out, let's say in this case, the audit. So this patient was positive on the alcohol screen question. They're given an audit to fill out. You're probably familiar with the audit. It's a commonly used tool in primary care settings. 10 questions, multiple choice answers, and at the bottom here in little, there's numerical value for each column here. So when someone circles an answer, it equals 1 point or 2 points or 3 points, 4 points. So it takes about a minute and a half to fill out. And this is the real screening tool that will put someone in a category of risky or harmful or severe. Scoring the audit. This is, as we'll see, what Epic can do when you enter in the answers. It will do this automatically. These are the scoring ranges we use to interpret the audit, and this is based on a study that was done recently. But basically, people often use some kind of zone to interpret the audit. You know, someone's going to be low risk, meaning they're drinking under risky levels, or they don't drink at all. And then the other three categories should get an intervention of some kind. Brief education is fine, but most often these get the intervention. And it's based on gender. So one advantage of the EHR is, you know, this would be kind of burdensome for a clinician to remember all these numbers to know what category their patient scores into. The EHR can do this for you. So clinician comes in and greets the patient and then addresses the reason for the visit. So I do want to emphasize that we don't expect clinicians to address the screening tool like right away. Typically this is done like at the end of the visit, maybe in the middle. You can do it whenever you want. But of course you want to address what the patient came in for. Later, when it is time, hopefully the clinician asks the patient permission to score the audit. So they have a look, and it's pretty easy to score. You just add up the answers for a total score, and on the piece of paper there it tells you what zone someone scored into. However, I do want to say there are other workflow options. Sometimes in some clinics, they have the medical assistant type in the answers to the audit right there as part of the ringing process. So the MA will wait for the patient to complete the screening tool and then enter it in right there. If that's the case, then the piece of paper disappears and the clinician doesn't know if the patient has completed an audit screening tool or not. So if that's your workflow, then there's a tool that can alert the clinician that something is due. So if it is entered before the clinician sees patients, a best practice advisory is triggered. So if the answers are high enough on an audit or DAS, this will appear on the clinician's screen as part of their Visit Navigator section of the EHR. Clinicians hate pop-ups, so technically it's not a pop-up, but it does appear. So this is one way. If you don't want a piece of paper hanging out with your patient in the exam room that a clinician has to score, and the MA is able to score it beforehand, we need to still alert the provider somehow, and this is one way to do it there. Another way to do it is some clinics will, instead of entering in the results into the EHR, when the patient completes the audit or DAS, they just take that audit or DAS piece of paper and just clip it on the outside door, hopefully in a confidential manner. And that acts as an alert for the clinician. So there's different ways to do this, obviously. You should tailor the workflow to what works best for your clinic. So let's say this patient is positive. Clinician performs the brief intervention or referral to treatment if indicated. This would also be the point where the clinician asks the patient, is it okay if a colleague of mine talks with you about this? This would be the warm handoff to a social worker or counselor. Both workflows are fine. Some clinics have these folks to hand off to, and some clinics don't. But if a clinician does the brief intervention, of course, we need to document this. And the clinician can do this during the visit or probably more frequently after the visit when they're catching up on their charting at the end of the day. Whenever it happens, they need to document what they did. So they're not going to document necessarily all the screening answers on the tool, or that's done later. And we'll look at that by someone else. But they need to document what they talked to the patient about. So let's look at a smart phrase, which is what we built. And smart phrase, also known as dot phrases, they automatically populate the progress note with a language that saves the clinician time or anyone else time when they need to fill this out. A lot of times this language is designed to meet billing requirements. There's certain things that you need to say to back up billing codes in case you're audited. It makes it easier on the clinician if this is an automated process. Another advantage of these smart phrases is they contain reportable data elements. These drop-down menus, as we'll see when the clinician clicks them, you can run a report on those later and see what's going on. So let's look at a smart phrase example that we built.
Hey, Jim. Before you dive into that, I have just 2 quick questions here for you that came into the questions box.
Yes.
So the first one is, does the brief intervention have to be 15 minutes in order to bill for it?
Good question. I will get to that in just a little bit. The answer is yes. Tragically, unfortunately, it's not based on evidence, but CMS decided when they created the CPT codes that record brief interventions that you have to spend at least 15 minutes doing the brief intervention and screening, which helps a little bit, to bill for it. And just in a couple of slides, I'm going to get into that in a little more detail.
Okay, thanks. And the second request, and we can follow up after the webinar with this, is for a reference to the study that looked at the audit scoring ranges.
Yes, I will be happy to send that. I was going to Google it. It was Johnson was the lead author on that, and Paul Steele at Mercer University in Atlanta. It came out a couple years ago. But yeah, I'll be happy to send out that link.
Sure. Okay, thanks.
So here's a smart phrase. So the first thing that will appear on the screen when you want to use like .SBIRT or whatever you call your smart phrase, in our example, is the sentence. Patient was given a blank screening form today. And if you hit F2, you have some choices there to choose from. The audit, the DAS, the craft, or the 5 Ps. Pick one, we'll say the audit, and the score, place the patient into the blank zone of use. And whatever names you give the zones of use, you can put it here. And we'll say this patient is low risk, meaning that they have binge drank at least once in the last year because they were positive on that single alcohol question. But when they were given the full audit, they did not score high enough to indicate that they're a risky drinker. So if that's the case, if you put in low risk, the next option is, you have 2 options. We did not discuss this further because, or in discussing this issue, my medical advice will say, so either you're going to talk about this or you're not. And there's a couple of reasons why you may not talk further about this with the patient. So let's pick that first one. We did not discuss this further because why? Well, in this case, the patient's low risk did not warrant further discussion. With adults, unlike adolescents, brief education to a low-risk drinker I don't think is shown to encourage low-risk use. With adolescents, there is some evidence that if you have a negative screen or an adolescent who has not yet used substances, and a physician does give some positive reinforcement to an adolescent patient, there's some evidence that shows that can further delay initiation of substance use, so it plays an important role in that case. But with adults, probably don't need to discuss this much further. However, there's other reasons too. Maybe your patient doesn't want to talk to you about this, which happens sometimes. That's an option. And then, of course, we ran out of time and we had to schedule a follow-up. This is kind of a convenient excuse, perhaps, for some clinicians who just don't want to address this, but it also is a valid excuse sometimes why you don't talk about it. So these are all options. And in this case, the patient's low risk did not warrant further discussion. And boom, those 2 sentences are enough. When a patient scores low risk as an adult, these 2 sentences, when we check in a way with a billing specialist in our department, this is sufficient to drop the 99420. And what is the 99420? Let's look at the codes here. These are commonly used CPT codes when it comes to billing for SBIRT processes. And in Oregon, they play a special role because beyond reimbursement, they're used by the state Medicaid to track if clinics are doing this, and there are incentive measures behind this. So basically, there's a code for full screen only. So regardless of what a patient scored on a screening tool, if they complete it, you can bill for it. Now, it does not apply towards the brief screen. That is too short of a screen in the eyes of Oregon Medicaid to qualify as a billable service, but an audit, a DAS, a craft, 5 Ps, any other full screens are billable. And whenever a patient completes it, you can drop this code. Then there's other codes, and the other codes are full screen plus brief intervention. And so that means typically if a patient's positive and then you do a brief intervention, you can bill these codes. But as mentioned earlier by the questioner, these have time minimums associated with these codes. If you want to use these codes, you have to spend, according to CMS, at least 15 minutes administrating, interpreting a full screen, and this is aggregate clinic team members, so this doesn't have to be done by the provider, plus performing a brief intervention. So considering that it takes maybe 10-15 seconds to administer a screening tool to a patient, maybe a minute and a half for them to fill it out, maybe another minute to interpret it, maybe that's 3 minutes, so that leaves still 12 minutes you have to spend doing a brief intervention to get to your 15-minute minimum here. So clinicians rarely have that kind of time. If you do a handoff to a social worker or someone else, maybe they have this kind of time to spend with a patient, maybe not, maybe they can build these codes. But clinicians, it's just very impractical. So these codes here are rarely used. When I look at the state data on counts of codes at Medicaid, it's all this, 99420. It's very rarely this, which is unfortunate because we'd like to track the brief intervention, but because of this non-evidence-based time minimum here, which is impractical in any busy setting, these codes are rarely used. So we're going to look at both codes though. So back to our smart phrase, if you have a low-risk patient, you can bill the 99420 and you don't have to document very much. These 2 sentences are sufficient and you're done as far as documentation. How about another example? How about if the patient scored higher? So they're given an audit, score placed them in the harmful zone. So based on our scoring system there, harmful zone kind of implies that there are some consequences going on with this patient. Probably is a mild, maybe moderate substance use going on, substance use disorder going on. So with these patients, you can recommend that they cut back, of course, or they try abstaining for a while. You can go either way here. And hopefully, in this case, if someone scores harmful, the clinician is going to talk about it. So the next choice there is, in discussing this issue, my medical advice is that the patient blank. And with alcohol, there's basically, 2 recommendations. I recommend you either don't drink at all or you cut back. And for men, of course, they have a different threshold to cut back than women do. So 3 choices: abstain, cut back for men, cut back for women. And this is nice because clinician doesn't need to remember these numbers. It's right here in the drop-down menu. You can just pick one of them. So for purposes of this example, let's say abstain. So I recommend that this patient abstain, perhaps for a period of time. Maybe try 3 months not drinking based on what you answered on the screening tool. Well, if you pick that, the next option that comes up, and again, these yellow sections are what you choose from. The white just appears automatically. These 2 sentences, when we consulted with a billing specialist, is sufficient for describing that you employed motivational interviewing, believe it or not, with a patient. We try to make this as minimum as possible. You may, of course, do more than what is documented here, but in basic terms, to make this feasible, at a minimum, you should say something about what was your patient's readiness to change. And if you use the readiness ruler, 0 to 10, this would give you an option to type in what the patient picked. So a 0 being you're not ready at all to change, 10 being very ready, what would you pick? Let's say the patient picked a 7. We explored why it was not a lower number and discussed the patient's own motivation for change. So in very basic terms, that documents that you explore your patient's motivation, which is the principle of motivational interviewing. And if you're a motivational interviewing trainer out there, I know you're rolling your eyes right now because that skill is more complex than this implies. But when you have 3 to 5 minutes with a patient typically to do this as part of a 15-minute visit where you're supposed to talk about the diabetes and their sore throat and other things, this is all we got. The next sentence would be the patient agreed to what? Maybe they agreed to abstain. Maybe they agreed to try to cut back. Or if they score high enough and you do a referral, they may or may not agree to accept the referral. Maybe they want to call a hotline. And of course, I should say in all these options, there's a free text option, which I don't really show here. But this is not supposed to dictate what a clinician is supposed to write. It's supposed to give you options, automated language. You can always use free text and change all of this if you wish. So let's say the patient was pretty willing to try abstaining from alcohol for a while. They want to give it a shot. So the patient agreed to do that and agreed to come back in 6 weeks. The next and last sentence It pertains to how much time you spent doing this, because if you want to build one of those brief intervention codes, they are time-based. And so we have to write down how much time we spent. Clinicians love this. We also have to say that we did a face-to-face brief intervention. That's another aspect of those billing codes you have to say. And administering and interpreting screening forms. So it's very wordy here, but it pops up for you, and your option is, did I spend less than 15 minutes doing this, 15 to 30, or greater than 30? Why did we choose those time intervals? Because they correspond with billing codes. So if you spend less than 15 minutes doing this, which is 99% of the time likely you did, unfortunately you can't bill for a brief intervention. You documented it properly and you did something good for your patient's health, but you won't be able to bill for that. You only will be able to bill for the screening-only code. So Epic will automatically drop at this point for you this 99420 if you click less than 15. If you click more than 15, it will automatically drop the 99408. More than 30, which I can't imagine ever happening, they'll click the 99409. So these are time-based codes, these two, that will automatically apply based on what you entered there. So when you actually do a brief intervention in screening, this is what a smart phrase looks like in the most, again, the most basic form possible that adequately backs up billing codes. Again, just a reference here to the billing codes again. Now that is adult, which is a two-step screening process. What if you're rooming an adolescent patient and you don't have a brief screen to look at to know if you're supposed to give the full screen? Well, how are you supposed to know when an adolescent patient is due? This is where the EHR can come in. The MA should go in and check the provider schedule, like we saw before. Say if the craft is due, or there's another place they can go into the visit navigator and check the best practice section. Because if the craft is overdue, the health maintenance will fire the best practice advisory. So it looks something like this, at least in the tools that we built. Hey, the craft annual drug screen is due today. This will alert the MA to give this to a patient. So this one-step screening process can be alerted in the exam room as part of the rooming process through the best practice advisory. And speaking of the craft, let's look at a craft workflow example, because we have a smart phrase that's kind of tailored towards that as well. And a quick review of the craft. This is given to adolescent patients 12 to 17, commonly used validated screening tool. There's 3 pre-questions here. You know, do you drink, do you use marijuana or anything else? If someone answers no to all of those, then they're supposed to at least answer number 1, because the leading cause of mortality for adolescents is car crashes. So they need to answer, have they ever ridden a car driven by someone who was high or drove themselves while high? So they at least answer that. If someone answers yes to any of these questions, so they have used something last year, then they're supposed to answer all these questions. And you add it up for a total score. So that's how the craft works. And interpreting the craft, like I mentioned earlier, younger adolescents who have not used it all yet, so they should get some positive reinforcement. That needs to be documented, in fact. If there's anyone who answers yes to the car question, because it's so important, you should discuss alternatives to driving or riding risk. Score of 0 means they have used, but they aren't dealing with problems. This is where brief advice comes in. Score of 1, they are dealing with a problem, but they are probably not experiencing a substance use disorder. This is where brief intervention comes in. 2 or higher, you should consider a referral. So again, the smart phrase can help you interpret the craft. So let's look at here. If you have an adolescent patient and you use a smart phrase and you type in craft, then the smart phrase will look just a little bit different, not too much, because your next option will be, at least in our version, some different risk categories: low risk, moderate risk, high risk. So again, based on that slide we saw earlier, this covers your bases on what's indicated. So let's say this patient is low risk. The next question asks specifically about the car question, because that needs to be asked separately. And let's say in this case, the patient answered no. The next sentence just is going to appear automatically, unless, of course, you don't say this. But I shared these results and recommended the patient abstain from using substances, drive while impaired, or ride with impaired driver. So this patient is not yet using substances, isn't at risk with a CAR question, so you need to give some positive reinforcement. And if you do that, again, the 99420 in this case is automatically dropped. So the clinician does not have to memorize the 99420. It'll be dropped automatically. And by the way, there are diagnosis codes associated with the CPT codes, and those are also automatically dropped. I forgot to include that, but there's 2 diagnosis codes Oregon Medicaid uses to be paired with the CPT codes, and of course, these tools automatically drop that as well. So clinicians do not have to memorize the CPT codes or diagnosis codes. How about if an adolescent patient scored higher? So what if they scored moderate risk, which means they have drank or used marijuana or another substance in the last year, but they haven't driven in a car like that? Well, you still share the same recommendation. I recommend that you don't use substances at all. That is always the recommendation for adolescents. There's no low risk level for alcohol or drugs. It's always abstain. But since this patient is using, you should do a brief intervention. You should explore their motivation. And the language here is the same as with adults, at least as a starting point of using the readiness ruler and discussing why it was not a lower number. Let's say this patient was a 3. So this patient's not really interested right now, very ready to stop drinking. Well, the patient agreed to, and these are some different choices here, they're not going to abstain today. Maybe they agree to avoid driving if they have been, not engage in other risk behaviors like having sex while using. Maybe they're ready to accept a referral, or maybe they're just ready to discuss it with a trusted adult. Whatever it is that they're ready to do, if anything at all, you can type that in there. And then again, if you want to use the brief intervention codes, if you spend a lot of time doing this, the same sentence here. Same time options, and same codes will be dropped according to how much time you spent. So that is an example for adolescents using a craft. One note here, of course these slides will be made available to you in a PDF format afterwards, but if you want to go to the SBIRT website, we also have examples of these smart phrases. And these aren't copyrighted or anything, so you can copy and paste this language if you want to build your own smart phrase. So there's a billing and documentation page on the website that shows this.
Jim, there's a couple other billing questions that have come into the questions box. Would you like to address them now or at the end of the presentation?
Sure, let's go for it.
Okay. So the first one here is actually a follow-up to our previous question about the brief intervention having to be 15 minutes in order to bill for it. So the follow-up question is, why do they allow or pay for shorter times than 15 minutes for tobacco cessation for billing?
Great question. I would like to know that. In fact, I was using that as a point of argument when I wrote a letter to the CMS director a couple years ago asking if I had it signed by a bunch of deans at our school. And I made the point that there is a CPT code that exists right now for, I think, 3 minutes for tobacco screening and intervention. So if you spend 3 minutes talking to a patient about their motivation to quit using tobacco, you can bill for that. Why is the threshold 3 minutes for tobacco but 15 minutes for alcohol? I'm not sure. Because again, that 15-minute threshold was picked out of thin air. There's no study that says 15 minutes is what makes an intervention effective for alcohol drugs use. So that is something above my pay scale as far as trying to make that change. I know that SAMHSA or CSAT at SAMHSA is trying to communicate with CMS to look further into that. So, you know, billing codes right now just aren't great, aren't well designed to support preventative services like SBIRT. So, you know, that's a drawback because reimbursement is one way to get folks to do this, but it's not a good method to rely on if you want to track this. Next question.
Okay. As an this is from an attendee. As an FQHC, we receive one reimbursement amount no matter how many procedures are performed. So can an LCSW or an LCPC administer the full screen and intervention and submit for billing?
Right. So if you have a non fee per visit payment method, the billing codes may not be important, but if you still want to use the billing codes for some other reason, you're right, only certain people are allowed to bill these codes independently. And if you go, well, maybe I can just do it here. If you go to our website, assuming you can still see my screen, we list who those people are, billing documentation. So these are the folks here. If you're a physician, physician assistant, nurse practitioner, LCP or LCSW in Oregon, you can bill for it. For Medicare, and our Medicaid codes, Medicare codes for this, you have to be one of these people. Again, I don't know why CMS chose to limit the kinds of people who can bill independently, because in my experience, it's actually CADCs and health educators who do a much better job doing this than a physician, because physicians are harder to train, to get them out of their practice and train appropriately. They don't have a background in this. But these are the rules. You have to be one of these people to bill independently. However, there may be a workaround around that. At least in Oregon, there's something called Incident 2 billing. If your clinic is allowed to do Incident 2 billing, any employee in your clinic under the supervision of a licensed and credentialed provider, which means they have to be in the building, can bill for this under that credentialed provider. So you may already be familiar with Incident 2 billing. If you're not, look, talk to your billing specialist, because if you can bill this way, then really anyone, a college-level health educator who's trained in this, can do SBIRT processes and bill for it under that licensed person. So you have to be one of these people to bill independently, and if you can't, you may be able to do it under Incident 2 billing. And again, I'm not a billing specialist, by the way, but I have gone down the rabbit hole, I guess, far enough to learn enough to share what I've found out. Any other questions?
Yeah, we've got a couple others coming in here. So are these codes that you're sharing CMS specific or Oregon Medicaid interpretation?
They are CMS. So Oregon, back to the screen here. So Oregon Medicaid uses these, chose these codes to use as a trackable data element, but these apply nationwide through CMS for Medicaid. However, your state Medicaid has to turn on these codes to be usable. In most states, they are turned on, but these are not specific to Oregon. Oregon just uses these codes in a unique way beyond just reimbursement to track as towards a performance metric. But if these codes are turned on in your state, they apply the same way, same descriptions and same reimbursement ranges.
Okay, while you're on that slide, we have a question about the CPT 99420 code. Do you know what the diagnostic codes are that are associated with that code?
Sure. I'll go back to the website here. Says, look at the CCO measure. So in Oregon, diagnosis codes play an important role, because the 99420, the technical definition of that is really general. It just means general health assessment screening. It doesn't mention alcohol or drugs. So to know if someone is dropping this code towards alcohol or drug screening in the state, and this is an Oregon thing, requires one of these diagnosis codes to be used along with the 99420. And this diagnosis code refers to alcohol, this one refers to drugs. But if you were to Google these Z codes here, they're not going to give you good definitions. I think this one means screening for alcoholism, which is a really poor definition of what we're trying to do with SBIRT. We're just trying to screen for unhealthy alcohol use, not necessarily alcoholism. But to give credit to the Oregon Medicaid, or to empathize with them, there's not great diagnosis codes to choose from. They had to pick something, and this is the best they came up with. So that's for alcohol. For drugs, this is even worse. This means like just unspecified screening, but that's because the other diagnosis codes that mention drugs are also have really poor definitions in regards to SBIRT. So for better or for worse, these in Oregon, if you want to meet the incentive measure, when you use a 99420, you have to also use one of these codes. HCPCS are different, and this does count towards the incentive measure in Oregon because some people are dual eligible, and so that's why we include these Medicare codes, but these aren't often used. It's usually CPT codes that apply for Medicaid and commercial. So again, on our website, you can look at these, but these are the diagnosis codes. And I don't necessarily recommend using these diagnosis codes to be paired with this if you're outside of Oregon. We're not claiming that this is the best way to do it, but this is what they've thought of so far. I hope that was helpful.
Thank you. I just have 2 more questions here. Do you ever have to use modifiers as a part of the billing codes?
That's a good question too. I forgot about that, modifiers. So back to billing codes here. So yes, when you're appending these CPT codes to your EMM service, you're probably going to use modifier 25, and that is for 99420. So when you use 99420, yes, you need a modifier 25. So if you have a 99213 EMN code, you have a very basic common use code for a patient visit, you drop a modifier 25 and then use this code. I guess I didn't mention that during this because, you know, this isn't a billing webinar per se, EHR, but the 2 are closely linked. These 2 codes, however, do not need a modifier, I have learned, because they are specific to drugs and alcohol. They're more specific than this, I guess. That's why, I'm not sure. But you do not need a modifier. That is based on the advice I got from our Medicaid person here in Oregon.
Okay. And lastly, could you just explain perhaps a little bit more about using the readiness ruler and why you explore with the patient why they didn't choose a lower number instead of looking for why they didn't choose a higher number?
Sure, I'll do that briefly. So a good illustration of the readiness ruler is if you use this reference sheet, which is what a patient looks like. When you're curious how ready your patient is to make the change, you know, people are on a spectrum. Some of your patients don't even see their substance use as a problem to begin with, let alone want to do anything about it. So you're going to be wasting your time if you're going to try to talk to that patient about what plan they have to change. Other patients will be really ready to change. They've been thinking about this for a while, so they want to do something about it. So you need to gauge your patient's readiness to change. And when you don't have a lot of time to do that, you know, you're not a counselor, you're not a psychiatrist, the 0 through 10 scale works well. You know, you tell your patient with 0 being you're not ready at all to change, 10 being really ready, where would you put yourself on that scale? And it does 2 things. One, it gives you a concrete number on a scale telling you how ready your patient is, and that's kind of more useful than if they said, I'm kind of ready or I'm really ready. And 2, it allows you to follow up with this great question, which is, well, you picked a 4. I'm curious, you could have picked something lower, like a 2. Why did you pick something as high as a 4? And that question kind of encourages the patient to think about what motivation does exist to make the change. Even if it's low on the scale, that act of verbalizing motivation to change is what enhances motivation to change. So it's something that helps your patient move up this scale. So if you want more information about using the readiness ruler, which is part of the brief intervention, there's demonstration videos on our website that you can watch, and curriculum slides also that talk more about the brief intervention.
Okay, great. Thank you, Jim.
Sure. So let's see, we got maybe less than 20 minutes. I'm going to be a little quick here. So we talked about the craft smart phrase. And what if a clinician, completes the visit, he's documented this. Well, in our workflow, he drops off that audit or dash screen form, if that's what he saw in the room. He drops it off in a little box. And later, an MA or someone else enters in data from those forms into the EHR. And how they do that, they enter it into a flow sheet. So we built a flow sheet just for SBIRT. Sometimes they're called doc flow sheets. And when the data is entered here, and this is both for the brief screen and the audit or dash, this is what updates that health maintenance. So this is what updates the EHR to know if the patient's due for a screen next time. So let's look at this flow sheet, the one that we built. I think it's called .SBIRT or SBIRT flow sheet. First thing that comes up are the brief questions, so the single alcohol question and the single drug question. And when you want to type in the answer, a little pop-up here comes up and says, you know, did the patient say none or one or more? Choose one. We'll say one. When you hit one, like I said, you've entered in something, so the health maintenance is updated. This patient has now been screened. The other thing that happens is when you enter one, the audit questions automatically appear because the patient is supposed to receive an audit if they're positive on that single question. So it's kind of nice, they automatically appear. You go to the next question, which is the single drug question. Let's say 0, so they don't use drugs. And then you need to fill out the audit. And you can just type in the answers here. And with the audit, of course, your answer choices are like 0 through 4. So you're typing in the answers, and when you get to the last answer right here, it automatically totals this. So here's the total score, and it says what zone of use it correlates with. So it automatically totals this for you and tells you what zone your patient falls into, which is nice. However, I don't know why you need to answer or put in each individual answer for the whole screening form. If you just wanted to put in the total score yourself, there's a manual entry here, and you can just type that in here. So some clinics will want all this, some clinics won't. But the point is, you got the brief screen answered, and you got the audit answered. How about a positive drug screen? So they were 0 on alcohol screening question, but they were 1 on the drug question. Well, then the DAST should automatically appear. And when you fill out this, the answers are 1 or 0 if you're familiar with the DAST, yes or no answers. And when you get to the last question and you enter that in, again, it automatically totals it for you. In this case, it's 2, and tells you what zone they fall into. So this flow sheet, again, is entered in maybe at the end of the day or when there's some downtime. We found out early in our process that clinicians, it's unrealistic to expect them to enter this in. So maybe it's a data entry person, maybe it's an MA, but at the end of the day, someone goes through these sheets and enters them in. So revisiting here what we want our EHR to do, we've covered all these so far. The last 3 remaining ones are handouts, reports, and syncing. And just a couple notes on that. Patient handouts are kind of our latest tool we've came up with. We created these documents that are 2 to 4 pages long that describe the risks of a patient's particular substance use. There's 11 different ones because they're based on adults, adolescents, and pregnancy, and they're based on alcohol, illicit drugs, abusive prescription drugs. And then with adults, they're even tailored towards adults who are not ready to change their drinking, who are ready to cut back, or who are ready to quit. So anyway, these are available on our website to be downloaded. Soon they'll be available in different languages, or at least Spanish in a way. Our goal, however, is to make them easily printed out as part of a patient visit. And we're exploring with Ocean right now if that's a possibility. So it's still in the experimental stage, and it may be a hyperlink. So in that smart phrase we looked at, you know, if a patient's positive, this may automatically pop up as a little hyperlink, like a one-word handout. And if you click on it, then you can choose which handout you want to print out. So that may be, a lot of clinicians have expressed a desire for this, so we're trying to make that happen. Another thing the EHR should do for you is make reports. Whether this is for your own internal quality improvement purposes or you're trying to meet performance metrics, you want to run reports to show what's been happening in your clinic. And if you build a flow sheet, and build a smart phrase, those are the 2 things that have the data to draw from to make a report. And here's one example of what you might want to report on. We did this with our resident training project. We wanted to know how often was the brief screen given when it was supposed to be given? How often was the full screen given when indicated? How often was a brief intervention done and a referral when indicated? So these are all things that you could report on by using tools like I showed you with the smart phrase and doc flow sheet. So these are the ratios, and these are, you know, made up percentages here. In a perfect world, this is what clinics, you know, would achieve. So that's one example of a kind of reports you could come up with in EHR. And then one note here, lastly, I think, you know, in the future for sure, it would be best if we could use tablets to do all this screening and perhaps interventions. You may know that there is some evidence that a electronic computerized intervention is shown to impact behavior towards alcohol use. But at least for screening, it would be nice if patients at a kiosk could fill this out, or be given a tablet, and that's because in an electronic form, you can have skip patterns, you can use more complicated screening tools that are longer. You don't have to mess with or manage, pieces of paper that can get lost. However, it's easier said than done. At OHSU, they're piloting this, but to get this to sync with your EHR, which is what you wanted to do, it's tricky. It has to be done lifetime. There's confidentiality issues. What if the tablets disappear? The portals take a lot of time to design. But this would be nice because the data theoretically could be entered into the EHR right away rather than relying on paper. Another part of this is already underway. My chart is what we call at OHSU the patient portal system, where through email, a patient can complete an electronic screening tool and submit before they even show up for their visit. And that, of course, takes some paperwork and burden off the shoulders of the clinic staff. So the future is definitely electronic. We're not there yet. Maybe you guys are. But it will be nice to have some great tablet software to do this for us. So what was our experience, just wrapping up here, doing this? It takes time and money, and with the Ocean project, that organization of FQHCs, all these tools I showed you did not come out at once. It took some time to, of course, build and design them, and then they were released in different stages. So first it was the flow sheet and HM function, later it was the best practice advisory, and then the last thing was a smart phrase. So this takes time, and it takes time because, well, here's what I learned. You need real practicing clinicians and other folks to sit on these committees and give advice to what the tools should look like, because they're the ones who are going to use these tools. And that means taking people out of their busy schedules and having meetings, and it's typically a slow process. And then the informatics person has to build these tools, pilot them, make changes. So this takes time, which means money. The Ocean project, they were lucky enough to get a grant from a CCO in Oregon, Care Oregon, who gave them some money to pay for the IT people to build these tools. So remember that. This may be something that you'll need a grant for too. And you need feedback from folks. You can't create this in a bubble in the informatics meeting and expect people to adhere to what you created. Yeah, it's an ongoing process where you're going to routinely make small changes to continue to improve this as performance metrics change and your health system changes. And then once you build these tools, of course, you need to train folks how to use them. So that's more time in meetings to make sure people are familiar with how to do this. So this is a substantial process to get these tools built. So I wanted to end a little early in case there's questions, and if there aren't, I'm sure no one's complaining that we ended early. But thanks for your time, and again, I want to say that I'm not an informatics expert or a billing specialist, but hopefully it was helpful to share with you what I've experienced in the last couple of years.
Thank you, Jim. That was a great presentation. If anyone does have any additional questions, you can feel free to send them into the questions box. You can also use the raise your hand feature if you'd like to speak live onto the webinar. I do have a quick question here about the forms on the SBIRT Oregon website. Currently, they're available as PDFs, but not as Word documents. Do you know if they'll be available as customizable Word documents in the future?
You may be referring to the patient handouts because the screening forms are available in a Word format.
I apologize. She is referring to the patient information sheet.
Yes. Yeah, if you want a Word version of the patient handout, the reason why they aren't up there yet is because the drop-down menus are getting quite lengthy because they're also going to be made available in Spanish. So to have them in Spanish and English and Word plus PDF, there's going to be like, 24 drop-down menu choices there. So just email me, and I'll be happy to send them to you in a Word format.
Sure, and we can connect you both after the webinar here.
Yeah, my email address is right there on the slide.
Well, it looks like we don't have any additional questions coming in, so I'm just going to take this time to go over the continuing education information and our evaluation information. I'm actually going to take the screen back from you, Jim. So I just want to thank everyone for joining us today. You're going to receive a few emails from us following this webinar. In these emails will be a link to a recording of the webinar as well as a PDF version of today's slides. There will also be included a link to the evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintaining our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NADAC or PCB CEU. Should you choose to skip the evaluation and proceed directly to the CEU request form, just leave all of the questions blank on the evaluation. I also just want to let everyone know some of our upcoming events. We do have a SBIRT for Youth Learning Community session planned for January 26th, sorry, that should say 2016, from 1 to 2 Eastern Standard Time. And we are currently planning a Shaping Up Your Motivational Interviewing Skills webinar featuring Kate Speck for February 2016. That date is yet to be announced. Again, we want to thank everybody for their participation today. If you have any lingering questions that you didn't get to ask on the webinar, feel free to email us at info@ireta.org. Okay, I think that's it for us. Thank you, Jim.
Thank you.